Yet some of them are called drugs and some are called medications. And there's no war on medications, but maybe there should be.
This is not in the past. This is always characterizing the use of mind-altering substances throughout history. At the same time, the same substances are prohibited and they're promoted. So it's not that just some are demonized, but some are only demonized because others are praised and promoted and advertised and recommended and prescribed.
Somebody get this guy some help!
Or, put more simply,
If you need help like this guy, call your own doctor.
I wanted to provide a brief introductory monologue prior to releasing this series with David Cohen, a clinical social worker with nearly 50 years of experience, who's been a major advocate for patients' rights and informed consent throughout his career. This conversation was recorded about a year ago, and the plan initially was for Mr. Cohen to come back and talk more about forced or involuntary treatment in mental health. But David and I had at times a contentious argument, even though we clearly agree on 95% of the things that we're talking about, including the need for better clinical trial designs stacked against pharmaceutical companies who stand to profit to regain our scientific credibility, and that we're living in a time of drastically over-medicating children and adults, both in psychiatry and medicine as a whole. However, I felt like David was not nuanced enough when discussing drugs and medications and took more of a rubber band approach once he had seen such poor care and bad outcomes in clinical practice, snapping back in the other direction and revolting against all forms of biologic explanation or treatment of mental illness. I understand that we don't have it all figured out, but that also doesn't mean we don't have anything figured out. I also understand David has lived through a time where schizophrenia was caused by poor mothering, which later transitioned to a chemical imbalance theory around dopamine. So maybe it's me that's wrong in my opinions, but I just don't think you can throw everything out because of inconsistencies in understanding the mechanisms of action around schizophrenia and other mental illnesses with strong genetic or biologic underpinnings, at least based on twin studies. For example, when you find a family of 10 boys, 6 of whom are schizophrenic and have a common genetic mutation in common symptom presentation, I think you can state with a fair degree of certainty that those genetic influences for the Galvin family specifically were important indicators of biologic cause, or at least a major contributor, even though I won't discount the role of epigenetic changes based on lived experiences. Our discussion gradually shifts towards the war on drug users and our current drug epidemic. David takes the stance that all of the drugs, including the illicit and ultra-powerful synthetic fentanyl and less powerful natural morphine derivatives, as well as unique pharmacologic mechanisms like buprenorphine, are equal. In my opinion, I agree that there is not as wide of a divide between legal and illicit drugs as pharma and regulators want us to believe, but not all drugs are created equal. Each has a unique set of characteristics and pharmacologic properties and effects on the user, warranting a unique conversation around potential benefits and potential risks. Sometimes minute differences in chemical structure significantly change how a molecule interacts with its environment. A couple of specific points to make. Adderall, or amphetamine dextroamphetamine, is not the same as methamphetamine, though the comparison of the two is warranted. and holding some room for unknown or unappraised long-term risks associated with Adderall is reasonable. While it is significantly less potent, I do maintain some concerns about long-term neurotoxicity. Ritalin or methylphenidate does appear to be a safer alternative in terms of neurologic, cardiac, and psychiatric risk due to a different mechanism of action that does not flood the synapse with 1,000x dopamine and norepinephrine molecules like amphetamines do. Suboxone, or buprenorphine, does have its problems in terms of how tightly it binds to the opiate receptor, causing a difficult time in withdrawal for the user. But it also blocks the effects of fentanyl in the person using illicit drugs. So that part of its mechanism of action can be very useful, even life-saving, especially when compared to the full agonist methadone, which Suboxone has been gradually replacing in addiction treatment over the last couple of decades. To David's point, do some entities want users to remain on Suboxone forever because it promotes profits? Sure. But some users prefer to remain on Suboxone forever because it promotes their stability, while others want a clear plan to be able to come off of it once they feel established in their sobriety or decreased use. The stark reality is that oftentimes drug users are not willing to take a full opiate blocker like naltrexone or Vivitrol because it will throw them into an abrupt and intense withdrawal. So I've got to be willing to work with them, not adhere to just the ideal situation. I would love it if all of my depressed patients were willing to exercise as their main form of treatment. And I certainly try to emphasize the importance of physical activity and dietary change. But sometimes patients are not willing or able to do this, especially early in treatment. Sometimes it does require the use of a medication to use as a tool to instigate some of those changes. So there has to be more nuance in these discussions so we don't lose people, for example, to overdose when they would have been protected if they had buprenorphine in their system. Due to its strong binding affinity, other opiates are unable to bind, and buprenorphine does not affect respiratory drive, which can kill somebody. Similarly, not all forced treatment clinical situations are equal. For the catatonic patient who's at risk of dying from their severe medical condition, to the apathetic patient at high risk for suicide, to one who's under the influence of psychosis that may be putting themselves or someone else in danger. There are certainly exceptions to forcing someone to engage in treatment. But, as we learned in our recent conversation with Stephen Hayes, and as David points out again here, labels have been historically utilized to single out groups of people for nefarious ulterior motives. So anyway, I wanted to take a minute to clarify some of my stances and why I think this conversation is important prior to playing it. David certainly makes a lot of sense, a lot of great points, and we are in agreement on so many of the issues. I just wish he would have made more room for the discussion of the nuance involved in these sometimes very complicated clinical care issues and biologic explanations of our illnesses. Anyway, enjoy, like, subscribe. We need more listeners, more viewers, more subscribers so that I can keep this thing going, hopefully for years and years and years to come. Thanks. Tell me about the most influential aspects of your training.
I was trained and experienced as a clinical social worker to start with almost 50 years ago. And the first title I think I had was social aid technician. I was sort of a junior social worker in a family service agency in Montreal, Canada. And I'm talking in the middle 70s. So almost 50 years ago, I started my career into the mental health system. Got experience for 10 years or so, worked in numerous settings, and then went and got a PhD in psychiatric epidemiology in the long-term consequences of antipsychotic drugs on people who were deinstitutionalized from the hospitals. I did that at UC Berkeley back in the mid-'80s, and then returned, became a professor of social work, social welfare in different schools in Canada, in the United States, a little bit in France. My early training exposed me principally to family therapy, seeing how a symptom could represent something more than just a dysfunction inside an individual. So I learned to see things in a context and was acutely sensitive to the effects of context, to unspoken communications among members of a family. I also began to consult with numerous residential treatment services, family service agencies, even small hospitals and community centers that were dealing with people we'd call today the seriously mentally ill. And so I opened a private practice. I worked with people, but most of my experience as a clinician has been with helping people come off psychiatric drugs, reduce their use of psychiatric drugs safely, assessing their functioning, assessing why they came on drugs, and forming my own judgment of what would be in their interest and communicating it to them as honestly as I could and as carefully as I could, and to allow them to communicate that to other people in their environment, their family, their physicians, etc. I've done a lot of that. I do less of that now. I'll help supervisors of people and I'll do pro bono work and everything and give workshops, but I'm less involved in the day-to-day. So I have extensive experience in counseling people in crisis situations and in crisis, but quiet crisis also. But most of my work has been as an academic, as a student of drugs, how their general uses, drugs, prescribed psychiatric drugs mainly, but I put them in the same ecological niche as all drugs, all mind-altering drugs are all in the same niche for me. Some just happen to be in favor today, they'll be out of favor tomorrow, and vice versa. And we can discuss that, say, with respect to the psychedelics that are now going to be legalized in 5 years or whatever. We can just see how that might influence the psychiatric treatment system, et cetera, because these things have been occurring for 150 years at least. And so I look at drugs and I look at their harmful effects a lot. I think maybe that's been like my specialty, the iatrogenic effects of biological treatments, including drugs and including ECT and things like that.
I'm curious about your personal philosophy, but also, was there any sort of turning point? Because, I think we go into a medical career or medical field, maybe a little bit naive and green and want to think that the medications that you're prescribing all have some sort of benefit in the right patient population. But was there any sort of turning point for you where you said, gosh, I really don't know how well this stuff is working, or thought that the drugs were potentially causing more harm than good overall?
Great question. I think I would have to say there were many turning points. And I'd have to say again, the first turning point would be my own experiences with drugs as a youth in the 1960s, let's say, and 70s, which is that understanding how powerful an artificial mind-altering experience could be for self-awareness, for understanding, spiritual growth, things like that. And then having a sense that this could never be right if it was forced on someone. I don't know if that's a turning point, but that was an understanding that I gained as a youth in my teens, and I carried over eventually into everything, into my education. So I was already primed to see drugs as quite special things that required the most freedom in order to benefit from them. There were things that you willingly went in, but it were never things that you would say, you need to take this. I just thought that as a teen. And so when I encountered forced treatment, which I did very quickly as a beginning social worker, as an apprentice social worker, I was already assigned to kids who were taking drugs and for some reason found me an interesting person to discuss that with and tell me that as soon as they were believed to be taking the drug they had been prescribed, then they were seen differently by others. And I said, oh, what do you mean? They said, because if I stop taking them and they don't know it, they still treat me as if I'm taking it and they treat me differently. And so that was another turning point. Wait a minute, you mean that somehow these drugs alter how people see you. If they think you're on it, they see you as it's okay. There's nothing we need to do about your behavior because you're on a drug. But if they know you're not on it, as soon as they're aware of that, they'll say, hey, what's up? They'll get nervous and think that you need to be doing something. So I thought that these were like special substances that way. There was something interpersonal about their effect. It wasn't just you ingested it and the chemistry was acting. It was something much more social about expectations and unspoken perceptions. And it was much deeper, layered than that. And again, it was from the clients themselves. They explained that to me because I was a young man and I was open and friendly. And so they thought they could speak about it with me. So there was that. And when I spoke about it to their prescribers, I got this sort of barrage of, no, they don't know what they're talking about. And they sort of just medicalized it. It's just, they're not complying. It was turned around in a way that made it seem like, hey, wait a minute, they need to listen more to these people and their experience in order to understand better the effects of what they're prescribing. So those were the early turning points that were just ingrained in me almost from the start. So I was primed to look at the situation critically, and that made me want to study, well, what is it? Why are we prescribing these drugs? What's so good about them, really? And that's when I seriously studied the whole gamut to see, okay, what are the justifications offered? What are the arguments for or against? What are the facts? What's known? And so there were other personal encounters with people, forced treatment, definitely. The first client that I had to sort of drive into the hospital, who in fact only wanted to be in the hospital, but knew that she had to keep providing and letting me know certain symptoms, the grease coming out of the tap rather than the water, and I'm scratching to get the grease off. Look at the scars I have here. And I would be afraid of that. But in fact, it was another communication that I need to be in the hospital, because as soon as the person arrived in the hospital, everything disappeared. And she was also happy to be there because her place was terrible. And I'm talking to you decades ago. And so all of this, there was this nascent understanding that there's a language being expressed and there's communication that is way beyond what a person, just tells you with words, or it's the disturbance is not her disturbance, it's us being disturbed, it's needs not being met, it's stuff like that. So I had that beginning view that I brought to my encounters with different troubled people.
Yeah, and just for a little bit of background for listeners, psychiatrists and social workers often work closely together. And ultimately, I've learned more from some of the social workers that I've worked with than a lot of the psychiatrists that I've worked with. And I loved what you said about, you really got to listen to your patients. Yes, it may not always be the direct form of communication that is obvious and apparent, especially in other medical fields, but there are always grains of truth or reality, even in those with severe mental illness. The example that pops into my mind, I don't know if you've seen this HBO documentary called Six Schizophrenic Brothers.
No, but I did see a picture or poster of it.
So out of 12 kids, 6 of them developed schizophrenia with a more and more severe course with each successive child. And the oldest, who ended up dying in his 40s, the day before he died, he was in the midst of a psychotic episode. He went to actually attack his mother, saying, "You have shot me in the heart. You have shot me in the heart." And, she's trying to do what she can to help treat his condition and make sure he takes medications and goes to see psychiatrists and doctors. The next day, he died of heart failure. It's almost like he understood, he felt that there was something going on, but because some of these severe mental illnesses really impair the ability to communicate effectively, especially verbally, he couldn't put it into the right words, but he knew that there was something going
Something
on.
wrong.
Right.
with his heart. Yeah, yeah. And so I hope we get to discuss this notion of this illness impairing the ability, and so we need to treat the illness. I have a different view on all of that and the use of that language, but for the time being, I think that the general point you're making, which is that often people who we call psychotic and so forth, diagnosed with conditions like schizophrenia and the spectrum of all of that and psychotic episodes and so forth, they speak in metaphoric language. They very often speak in very, concrete language, almost like a kind of a strange poetry that you need to step back a little bit, and it can only be clarified by deeper discussion if that were possible. Very meaningful to them. It actually expresses a truth, and it's not it's rarely disconnected from reality. It always has a link to their lived experience, but they express it in mystical terms, religious terms, mystical terms, and in the most concrete, direct ways that they feel. And so, shot me through the heart. If you widen and put a little extra words in there, it could mean, my heart is really in pain, it's been pierced, it feels like that. Now that you did it, that's something else.
His mother was the one who would kind of mandate that he receive treatment over the years.
Right.
To comment on something else that you said, it has to be interesting for you to have gone through this period of time where governmentally we set out on this war on drugs that really ended up being a war on drug users and certain populations of people using drugs. But all of that is super interesting to me because it's a war on, as you said, there's not a difference in, all of these are mind altering substances, yet some of them are called drugs and some are called medications. And there's no war on medications, but maybe there should be.
This is not in the past. This is always characterizing the use of mind-altering substances throughout history. At the same time, the same substances are prohibited and they're promoted. So it's not that just some are demonized, but some are only demonized because others are praised and promoted and advertised and recommended and prescribed. One user gets acceptance in using a drug that's done according to the standards of pharmaceutical purity and manufacturing and what have you, and they get it prescribed in a neat package, and they go to the pharmacy and it's dispensed to them by a smiling person, and their insurance pays for it. But the same substance, not just even the same class, the same substance on the other side of the street is only available in impure form, through a black market seller, and you have to hide, and they have to hide for you to get it. And there are criminal penalties for you doing this, for using it, for that person selling it to you. But it's the same substance. It's methamphetamine, which is also available by prescription and used to be somewhat prescribed, small percentage for ADHD, may still be for some, because we have Adderall, which is amphetamine, which is another form of methamphetamine, or the other way around. The point is, either the same substances. We see it with the opiate treatments. In fact, I just saw a big headline from the NIH saying, the solution to the fentanyl crisis, prescribe methadone. This is an official research announcement that I just got in my email box yesterday. And so it's like, whoa, methadone, that's an opiate. A fentanyl, that's just a higher potency opiate. So wait, we don't want you to take this one because you're going to get it on the street, even though fentanyl is also available, and it was designed to be available by prescription as an anesthetic for heart surgeries. And that's still on the books. It's just that it's been made illegal because it's so potent, but it's the same as methadone, which is a slower acting opiate. So take the one that's in liquid form, wean yourself off from the syringe and the illegal form, but it's the same drugs. So the war is on the users, but it's a fake war. You can't fight an inert substance that doesn't come to you. You have to go and take it and put it in your body. These are inert substances. If you don't pay attention to them, they're just going to stay and lie on the shelf. So how do you fight an object like this? You have to fight the people who use it. So we promote some people, some uses, we praise them, we say, look at them, they're in pain. And then we repress other users and say, look at them. And the stuff that's going on in the society at that time, the divisions between people of different colors and who's bad and who's good, who's got the right gender or not, who's the immigrant or the native, who's the true American, the not so true American, whatever it is, those divisions, which predate war on drugs or whatever, come in and, stamp themselves on the dynamic of what's prohibited and what's not. It adds another kind of layer. So we can't see clearly that we're constantly prohibiting drugs and constantly promoting them at the same time.
Right.
It's just who's doing it.
On the methadone topic, this is one of the big reasons why I am so passionate about what I talk about and what I do, because I come from an area of the country that Oxycontin was the drug epidemic, but I didn't realize it until I went to medical school. And I learned that my people were preyed on by the pharmaceutical industry. And then the regulations scaled back who was able to get those drugs. And that led to, heroin bursting onto the scene and becoming widely available and widely used, and increased rates of IV drug use. And then fentanyl comes around. But that's a big reason for the passion that I have, is I have seen the harm that particular pharmaceutical company, Purdue Pharma, bestowed upon Americans and brought that whole epidemic out, with the test market being my area, my region. So, that's a very, very important topic to me. I did just want to mention with methadone, I don't really understand pharmacologically why we're using, and I don't want to spend a whole lot of time on this, but, I understand the use of medication-assisted treatment, especially in somebody who tells me, hey, I don't want to use fentanyl. It could kill me. It leads to way too high of ups and downs. But I still don't understand the methadone craze, because it's a full agonist that people were overdosing on just methadone before fentanyl was ever widely available. And then, buprenorphine or Suboxone has kind of a unique ability in that it has a ceiling effect and does not cause fatal overdose by itself. But we need to give people options on how to utilize it to come off of drugs. It is a great tool if somebody feels more comfortable in their overall safety by continuing it long term. I'm okay with that. But what I see more often is, in working in several different addiction facilities, is kind of telling people without telling them that, hey, you're going to need to take this forever. And that makes sense from a business standpoint, that they want you to come back forever. But it also has a very, very important role in when somebody's early in their recovery. And I have lost friends to one-time use of something bought online that was cut with fentanyl. And had they had Suboxone in their system, it does have a blocking effect of that. But again, there's got to be more nuance with its use and with addiction treatment.
Where I differ a little bit from the way you think about this is that, again, to me, and I'd love to see evidence of the contrary, but maybe besides naloxone, the brand name of which always escapes me now, I don't know if it's Narcan or not, which is that sort
Narcan and or Vivitrol is the long-acting.
Right. And so,
naltrexone.
but almost every drug, and again, methadone is a classic example, you just substitute one for another. The other one happens to be the one that's not favored now. So we say, this is not good for you. And now exactly why it's not good is not necessarily just the drug itself, that particular formulation or compound, because in the case of fentanyl, it may be argued it's just so powerful that it is, you really need 3 chemists with an electron microscope to find what is that dose that's not going to kill you. And so that is just in itself the prima facie case that should not use this drug. It's just too dangerous. It's just too unstable to carry. This is too strong for you. But it's an opiate. It was actually first prescribed with that very powerful, too bad I forgot so much of that early history. But fentanyl has a fascinating early history and developed as an anesthetic. And that notion of like going from going to haloperidol, let's say, or going from Valium to Xanax. That is going from a long-acting, slow-moving tranquilizer of, benzodiazepine to then going that you need, 12 milligrams or 1 milligram to going to Xanax where you need, 0.2 milligrams or so, which is, again, and quick acting, immediate acting, short acting, supposedly. That language makes it seem like, oh, it's just going to go in and out of your system. So it's out of your system. What do you mean in and out? It's going in and out quickly. If somebody runs through your house at flash speed, all the furniture is going to go flying. So it's not that it's in and out and there's no more effect. It's in and out and you have to clean up the house afterwards because the speed just disturbed everything. My point is, it's the same drugs. They are the same drugs. All the medication-assisted treatment, the treatment is the same drugs that they don't want you to take on the street. They just want you to take it in a controlled setting, in a controlled manner, in a cleaner formulation, to be able to drink in a cup, to take you away from everything else that's tied to your illicit, injected, harm-producing use of the same drug, same class. Some might be natural, some might be more synthetic, opioid versus opiate, but they are the same class of drugs. So when you tell me, oh, Suboxone has a little ceiling, yeah, sure. Methylphenidate, Ritalin stays, 5 more minutes in the brain than amphetamine, Adderall. Yes, there's a little difference, but they are prototypical stimulants, same class of drugs. The animals don't see the difference when you put them on. So it's like the drugs are very similar, but it's all the social construction of what's good for you, what's proper for you, what medical science is deemed best for you, and everything else, what's misuse and abuse. So when you said, why do we call some medications and some drugs? So what you need there is not pharmacology to understand this. It's history. It's history. You just see it. You just see, when did they start to divide them? About the 1910s, 1920s. Why? What was the purpose of really making that difference? And then you start to see it was complex. In the United States, it very much had to do with competition from Chinese immigrants on the West Coast. They were using opium. They had to be disabled. So what were we going to do? Well, the labor movement said, forbid opium, break the opium dens, because obviously that's not going to help them. Let's do something that's not going to help them. So this is a big part of why we turned against opiates in this country, because the Chinese immigrants who competed with the white laborers, and they competed by taking any money. They would work for any cost. That was too much. And so they had to be fought that way. If opium was so bad for them, we would have said, good for them, let them keep using opium. But once we got rid of opium that way, and then we got into more like heroin rather than opium, then the Chinese, they lost interest in these drugs. They lost interest in that, and they moved on, and they did whatever they did. But the rest of us got stuck with, now it was in its purified, more synthetic form, heroin, that we had to deal with. What I'm saying is, again, history, appreciation for what went on, and what comes around again and again.
I appreciate that sentiment. I do want to clarify my own stance because, again, I have seen people die. I would love it if everybody that I worked with in addiction was willing to take Narcan or the long-acting form of it that blocks the opiate receptors. And if they do slip up and use a really, really extremely potent opiate like fentanyl, or use it unintentionally, which is rampant these days with it being contaminating the entirety of the drug supply. If they're not willing to take that blocker, I think it is so important, especially early in recovery, getting all of your social aspects of recovery and the community aspects in line to have that protection. But I don't want to spend too much time on that. I could, you'll get me really going on the drug epidemic and all of the, poor policies that we have surrounding it and that helped create it, et cetera, et cetera. Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.
Or, put more simply,
If you need help like this guy, call your own doctor.
thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show, or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.